I think I'm not able to share my screen. Just a minute. Oh, yes. Let me know if are you able to see the PPT? Just
we can see your screen, but not the presentation.
Now?
Yes, but could you please put it in full view?
Yeah. Can I start?
Yes, please. Thank you.
Pleasant good afternoon to one and all present here, and thank you, Scientex Conferences, for allowing me to do this presentation. And I'm Dr. Mithra, consultant dermatologist and aesthetic physician from Chettinad Speciality Hospital. I'll be doing a case report on severe exercise-induced urticaria with muscle injury. We know urticaria is a common condition. About 15 to 25% of the patients experience urticaria once in lifetime at least. It can be broadly classified into chronic inducible urticaria and chronic spontaneous urticaria. Under chronic inducible urticaria comes the physical and non-physical urticaria. Under physical, we have a lot of urticaria like solar urticaria, vibratory angioedema, heat and cold induced urticaria, delayed onset urticaria, and dermatographism, which is very common. Under non-physical, you see cholinergic urticaria, any contact urticaria, as well as aquagenic urticaria. And the most common causes of chronic spontaneous urticaria is infections, food, drug intolerance, autoimmunity, autoactivation of coagulation cascade. And it's seen that about 2/3 cases of chronic spontaneous urticaria is because of physical urticaria. And females are most commonly affected, and the most common risk factors are obesity and malignancies. So coming to exercise-induced urticaria, it is very common these days because of the increased awareness about benefits of exercise, high intensity training, and fitness programs. So what really happens is that, just a minute. So what really happens is in exercise-induced urticaria, it is seen that about 50% of the patients have atopic association, and also 50% of them have a first-degree family relative who have any kind of allergic manifestations like sinusitis or allergic symptoms. And it is in contrast with to 20% of the population who have urticaria. So the range of symptoms include mild urticaria, severe urticaria, and anaphylaxis. The basic pathology is increase in body warmth. And an increase in body temperature by more than 0.7 degrees Celsius can trigger mast cell degranulation. So the broadly classified into the exercise-induced syndromes as cholinergic urticaria, exercise-induced anaphylaxis, variants of exercise-induced anaphylaxis, familial exercise-induced anaphylaxis, food-dependent exercise-induced anaphylaxis, and exercise-induced asthma. The pathophysiology behind this is, as already stated, it is just increase in body temperature, and that leads to acetylcholine release and mast cell degranulation along with histamine release leading to urticaria. And the theories which have been stated in literature are, again, increase in acetylcholine release, increase in acetylcholine receptor sensitivity, and increase in histamine release due to cholinergic stimulation. And also decrease in protease inhibitor like alpha-1 anti-chymotrypsin. It's a mediator required for inhibiting mast cell activation. So another theory stated in recent literature is that there's lack of acetylcholine esterase in eccrine gland epithelial cells, and also along with decreased expression of cholinergic receptor M3 due to autoimmunity causes. This leads to increase in acetylcholine, thereby stimulation of mast cell degranulation leading to urticaria. So the variants, how they manifest actually. The first one being manifestations being cholinergic. In cholinergic, it is basically due to two causes, either active or passive. If it's active, it's majorly because of exercise. If it's passive, it's like due to fever or any emotional stress, or if a patient takes bath in hot water. They usually present with punctate type of lesions around like 2 to 4 millimeter in size, and it usually resolves within 2 to 4 hours. And these patients may have cholinergic symptoms like lacrimation, salivation, and increased urination if it is in severe spectrum. And it is rarely associated with vascular collapse, and bronchospasm is there mildly. Under exercise-induced anaphylaxis, as the terminology glows, there is vascular collapse and laryngeal edema, but here exercise is the only cause, and patient may have urticarial plaques instead of, unlike cholinergic urticaria. And food-dependent exercise-induced anaphylaxis, it is again where if a patient takes particular food 2 to 4 hours before exercise, they are more prone to get this anaphylaxis and they get urticarial plaques. The most common foods which are mentioned in literature are shellfish, oyster, hazelnuts, peanuts, and raw celery, and wheat, even apples, and all these common foods are mentioned in the literature. That is associated with vascular collapse and laryngeal edema. And another variant type where it's exercise-induced anaphylaxis, where again the patient it is exercise-induced, but here patient has punctate lesions similar to cholinergic urticaria associated with vascular collapse and laryngeal edema. And under familial exercise-induced anaphylaxis, it is still unclear the exact pathogenesis, but it is believed to be autosomal dominant. And there was a set of patients who showed decreased C2 and C5 in familial exercise-induced anaphylaxis. Next, exercise-induced asthma. It is majorly exercise-induced, and as you know, bronchospasm is the major pathogenesis behind asthma. It is present with no skin lesions and no vascular collapse. So majorly, how do we diagnose this exercise-induced urticaria is depending upon the clinical history. And also exercise challenge tests can be done for some patients who require for the confirmation of the diagnosis. It is usually done in a clinical setup where emergency medications are kept on standby. Along with combination of exercise, patient is asked to do like running, jumping jacks or squats. And a patient is asked to avoid any kind of food intake at least 4 hours before the test. And temperature, heart rate, blood pressure, and respiratory rate are measured before and after the exercise. And auscultation and SpO2 can be done to rule out any features of anaphylaxis. And there's one more test called methacholine test, which is positive in only 1/3 of the cases. And it should also be remembered that negative cases do not rule out diagnosis in case of methacholine test. So it's majorly the diagnosis depending upon the history. Coming to my case report. A 27-year-old male patient presented with urticaria lesions once in a week after 20 to 30 minutes of strenuous exercise for the past 4 months. And he majorly presented with punctate type of lesions, few papilla lesions and plaques involving his chest, abdomen, back, hands, and legs. Patient also gave a clear history of asymptomatic phase for 2 months when he was on abstinence from exercise. And no other history suggestive of any infections, allergens, anaphylaxis, or food agents triggered prior to exercise. Patient also gave one significant history where he said there was need of oral analgesics on the day of severe exercise to manage the level of body pain. And history of lesions after exercise and before drug intake helped us rule out the drug-induced or NSAID-induced urticaria. This was the clinical picture of the patient. He presented with erythematous, punctate type of urticaria lesions majorly and few plaques involving his upper chest, abdomen, back, hands, and legs. So on the basis of history, a severe exercise-induced urticaria was diagnosed, and it was with muscle injury based upon the investigations. So the clues for diagnosis were triggering factor. Patient clearly said that it was only on the day he did severe exercise, so which was once in a week, and it also correlated with the severity of the exercise. And also patient said that he was asymptomatic when he was not into any kind of exercise. And evidence of muscle injury was confirmed when patient said he required oral analgesics for body pain on the day of severe exercise. So after doing the blood investigations, basic investigations, they complete that count, renal function test, liver function test, and urine routine. All his investigations were normal except for liver function test, which showed elevated AST of about 354, normal ALT 51, and AST and ALT ratio was more than 6. In order to confirm the muscle source of the AST, we did a supportive investigation like lactate dehydrogenase, which was also elevated of about 690. So how the patient was managed and followed up was, patient was instructed to step down the intensity of exercise, adequate hydration, and short course of antihistamines was given for 2 weeks. This patient I saw it way back in 2020, and he's still under follow-up where patient is still asymptomatic with mild home-based exercise and he's not on any other medications. Coming to the discussion part. In our case scenario, it was very clear that patient didn't have any liver symptoms and they were absent liver disease. And the investigations also showed only isolated elevation of AST, which indicates that it is from muscle, and elevated LDH, which also indicates there was some kind of muscle injury for the patient. And studies from literature have stated that in normal individuals, when they're involved in severe exercise, ALT, AST, creatinine kinase increases in day 1 and normalizes in a week. So keeping all this in mind, we did go through the literature, and we remembered acute rhabdomyolysis, in which patients, muscle proteins get released and they may cause acute kidney injury and excessive body pain and all those symptoms. So in acute rhabdomyolysis, patients generally present with initial AST elevation followed by ALT, and AST-ALT ratio being more than 3. Usually, AST normalizes because of its short half-life. So why exercise challenge test was not done for a patient? Because he gave a clear history of saying I had muscle pain requiring oral analgesics on the day of strenuous exercise only. Blood investigation was suggestive of muscle injury, and it was not required when there was a clear definite history. And creatinine kinase was not done in a patient. Reason being, studies from literature said that elevation of creatinine kinase after exercise is normal in healthy and asymptomatic individuals. And aminotransferases may remain elevated 2 to 3 weeks after normalization of creatinine kinase. So being in our case, the patient had elevated aminotransferases. So there was no need to do creatinine kinase for us to confirm the diagnosis. And also being creatinine kinase as a renal clearance. So if a patient is given adequate hydration, it tends to get normalized soon. And probably our case was this patient was a case of impending or mild rhabdomyolysis who required only adequate hydration and rest. Patient did respond well for the initial management and did not require further investigations. So coming to exertional rhabdomyolysis. So exertional rhabdomyolysis, what really happens is there's significant elevation of AST and creatinine kinase in 24 hours. And ALT may remain normal even up to 48 hours, and peak AST or ALT ratio is seen on day 3. As already stated, aminotransferases may remain elevated 2 to 3 weeks even after normalization of CK. And in about 85% of the patients, aminotransferases and CK get normalized concurrently also. And CK generally gets normalized at the faster if adequate hydration is given or IV fluids are given because of its renal clearance. So keeping in mind all this, we have to remember the complications of exertional rhabdomyolysis. If it is a mild case, usually it's home-based management where we give adequate hydration, rest, ask them to step down the intensity of exercise. In case of severe, they may require an inpatient management where there's a risk of acute kidney injury, compartment syndrome, disseminated intravascular coagulation, cardiac arrhythmias due to electrolyte imbalance, and cardiac arrest. So what are the red flags in case of exercise-induced urticaria patients? If they have proportionate pain, tenderness, weakness, and swelling of the affected muscles, if there's delayed onset of muscle soreness, dark-colored urine, just look for elevation of creatinine kinase or any of these liver enzymes which might suggest some muscle injury. Usually creatinine kinase is 5 times its normal limit. For a patient to be diagnosed as exertional rhabdomyolysis, we generally do creatinine kinase. But if there are any evidence of muscle injury, you have a clinical history, the patient says I have very severe body pain requiring tablets and everything, you can do liver function test, which could also be an guiding tool to investigate further. Such patients require inpatient management because they have a risk of even death due to cardiac arrest. What are the learning points in our case? What we already know is that we know about cholinergic urticaria, exercise-induced urticaria, or anaphylaxis, which are managed with antihistamines and avoidance of exercise or stepping down. The lessons learned from this case: to elicit history of urticaria associated with intensity of exercise, to look for symptoms and investigations suggestive of muscle injury. And what's new? This was a case of severe exercise-induced urticaria with muscle injury. He was managed with stepping down the exercise intensity instead of complete abstinence. And the risk of rhabdomyolysis and exercise-induced urticaria must always be kept in mind. And these patients should be evaluated and asked for such history of muscle pain and muscle injury too. So what is still unclear is whether urticaria could be one of the cutaneous manifestations of acute or exertional rhabdomyolysis, whether all exercise-induced urticaria must be evaluated for evidences of muscle injury in presence of clinical history of muscle pain or soreness. Definitely, risk of rhabdomyolysis is present. Take-home message: a sub-entity called exercise-induced urticaria with muscle injury must be considered while managing urticaria patients due to exercise. Detailed history and minimum investigations guided an arrival of the diagnosis. Patient was managed with minor lifestyle change owing to the benefits of the exercise, and risk of acute or exertional rhabdomyolysis must be kept in mind while treating exercise-induced urticaria patients. And these are my references. Thank you for giving me an opportunity.